Dear audience, good morning. It is my honor to present my 12-month progress report of my PhD journey entitled The Application of Enhanced Recovery After Surgery Protocol to Improve Patient Outcomes After Surgeries. Allow me to introduce myself. I'm András Czébely-Lénárt. I'm a fourth-year medical doctor at Semmelweis University Department of Obstetrics and Gynecology. My supervisors are Ferenc Bánhidi, Balázs Lindner, along with our scientific methodology supervisor, Jakub Hoferica. Our vision is that every patient will get the best evidence-based care before and after surgeries, and our mission is to integrate the newest evidence-based routines into clinical practice. Currently, we have two ongoing projects. The first is about finding the proper bowel preparation techniques, and the second is finding the optimal timing for first oral feeding after bowel resection surgeries. My first project is investigating the patient outcomes in bowel resection surgeries with and without mechanical and oral antibiotic bowel preparation. This is a systematic review and meta-analysis, which we started in this year's September. Infectious complications are common after colorectal surgeries. The incidence of surgical site infection is 5 to 20% in the cases, and anastomosis leakage is between 2 to 10% of the cases, respectively. There are two types of bowel preparation. The first one is mechanical bowel preparation, which means digesting large amount of laxatives to expel fecal matter from the bowels. And the second is antibiotic bowel preparation in order to reduce bacterial load. Finding the proper bowel preparation combination is crucial to reduce complication rates, although the method remains controversial in bowel resection surgeries. There is not a widely accepted protocol for standard of care. Departments use conventional routines instead of up-to-date evidence. So that makes our aim to evaluate the optimal bowel preparation method to be used for elective colorectal surgery to minimize postoperative complication rates. That arises our clinical question: what is the proper combination of mechanical and oral antibiotic bowel preparation to reduce postoperative complication rates in patients undergoing surgeries with bowel resection? We use the PICO framework. We are focusing on surgeries with bowel resection, and the intervention and control groups is the different combinations of bowel preparation and no preparation at all. Our outcomes are postoperative complication rates, such as surgical site infection and anastomosis leakage. Our hypothesis suggests that combining mechanical and oral antibiotic preparation in preoperative routines will reduce the postoperative complication rates in surgeries with bowel resection. We conducted our systematic search in 3 different databases, and after the full text selection, we ended up with 89 eligible full texts. On my first figure, we can see the odds ratio for surgical site infection based on the RCT results. We are comparing the different preparation methods to no preparation at all. Below the value below 1 means less surgical site infection than no preparation group, and above 1 means more surgical site infection than no preparation at all. As we can see, the combination of mechanical and oral antibiotic bowel preparation shows a significant, clinically and mathematically significant difference from no preparation at all. And oral antibiotic preparation alone shows also difference from no preparation. Although mechanical bowel preparation seems to have no effect alone compared to no preparation. I would like to mention that we have very few number of studies with oral antibiotic preparation group, with a few number of patients. So after sensitivity analysis, we also included observational studies. And with these observational studies, we could reach a significant difference in the oral antibiotic preparation group, lowering the incidence of surgical site infection. On my third figure, we can see the odds ratio for anastomosis leakage based on the RCT results. And as we can see, mechanical and oral antibiotic preparation combined together also shows mathematically and clinically significant relevance compared to no preparation at all. The strength of our study is that it shows a comprehensive picture for all types of bowel preparation using the network meta-analysis system. We have the largest patient numbers compared to other previous meta-analyses, and after the sensitivity analysis, we also included observational studies, not just RCTs. Although there are some limitations, we have only a few number of RCTs compared combined preparation versus antibiotic preparation alone. And we have a lack of information about surgery type and resection site specific complication rates. Our conclusion is that mechanical and oral antibiotic preparation used together is the best approach to reduce complication rates, and oral antibiotic preparation alone has promising effects. So basically that is our implication for practice, that we always combine bowel preparation, antibiotic and mechanical bowel preparation as golden standard, and if some way mechanical bowel preparation is contraindicated, oral antibiotics should be used alone as well. Our implication for research is that the efficacy of oral antibiotic preparation alone should be investigated more, comparing oral antibiotics with mechanical and oral antibiotic preparation, and we need a more detailed reporting about complication rates specific for resection site and types of surgeries. Currently, we are writing the manuscript, which we would like to finish in September. So my second project is comparing the safety and efficacy between fasting and early oral feeding after bowel resection surgeries. This is a systematic review and meta-analysis. Conventional protocols after bowel resection surgeries recommend fasting with administrating only just intravenous fluids until full bowel function recovery. However, enhanced recovery after surgery protocol suggests early oral feeding, as it reduces the length of postoperative ileus and the length of stay at the hospital. We can see that the resolution of the ileus is shortened, as well as the length of stay at the hospital in the early feeding group. Our aim is to investigate the advantages of early postoperative oral feeding. Our clinical question is, what is the optimal timing for first oral feeding after bowel resection surgeries? We also use the PICO framework. The patient population is bowel resection patients after the operation, and we are comparing early oral feeding and fasting, and we are focusing on ileus and length of stay as primary outcomes, and postoperative complication rates as secondary outcomes. Our hypothesis suggests that early oral feeding after bowel resection surgeries reduce the length of postoperative ileus and length of stay at the hospital, and could also reduce complication rate. Our clinical implication is to ensure quicker and safe recovery after bowel resection surgeries. With our first project, we want to finish it by this year, September, and the second project by the end of this year. And for last but not least, a smooth sea doesn't make a skilled sailor. Thank you for your attention.
Congratulations for your nice presentations. I have a question regarding your first project. Which kind of antibiotics were used in the preparations?
Well, In the RCTs and different hospitals use very diverse types of antibiotics, so we couldn't use a template. The most used is the metronidazole usually for the surgeries, but they are combining it together with all types of antibiotics. But most of the RCTs suggest that it doesn't make any difference, the chosen type of antibiotic.
Thank you.
Congratulations, nice presentation and nice progress. My question would be regarding your second project. And what do you mean exactly by early oral feeding?
Well, early oral feeding means that the patient can drink after 8 or 6 hours after the surgery, and can eat at the day of the surgery in the evening. And early fasting means administrating only intravenous fluid and nutrition until full bowel function recovery.
Okay, thank you.
Thank you for the presentation. So I also have a question about, although you were mentioning that in between the limitations that the type of the surgery was not known, but it means that even, like you didn't make any differentiation between the laparoscopic surgery and the open abdominal surgery, or? Yeah,
thank you for your question. There are some articles that focuses only on laparoscopic surgeries or only for laparotomy surgeries. But most of the articles just describe it in the patient characteristic table, that how many of the operations was open or how many was just laparoscopic, and in the results they don't describe it, or they don't separate the two groups. So they are reporting together the types of the operations and the resection sites as well. So it would be good to know that it was a left side resection, right side colon resection, or a upper rectal resection. So that was our suggestion for research.
Thank you for your presentation. I have a few questions. So you mentioned in your presentation that if mechanical bowel preparation was contraindicated, then the antibiotic should be used alone. What kind of contraindication you mean here?
Thank you for your question. For example, if there is an emergency situation when it's not contraindicated but can't be performed because of the timing, and if there is a full bowel stricture or ileus, then we can't perform mechanical bowel preparation because of the obstruction in the bowel.
And were there some studies comparing directly the mechanical and the antibiotic?
Excuse me, sorry.
Were there studies comparing directly the mechanical and the antibiotics?
Yes, there are like mechanical bowel preparation alone, and comparing oral antibiotic preparation alone, if I understand well.
Yes, like 2-arm studies. In the same study, one arm receiving mechanical preparation, the other arm receiving antibiotic preparation. Were there studies like this?
No, there were just, we could only perform indirect comparison, but I think they didn't perform it because it is not so relevant for the, so basically over the last decades, the big question was whether we should use mechanical bowel preparation or no preparation at all. And the last few years started to focus on combining mechanical and oral antibiotic preparation, and versus oral antibiotic preparation alone or mechanical bowel preparation alone. But the question was, they didn't focus on the question oral antibiotic alone or mechanical alone, because both of them are worse than combining them together.
Right, thank you. And my last question would be, how do you think the bowel preparation would decrease the incidence of anastomotic leakage? What is the pathomechanism here?
How would it increase or decrease? Decrease. Like mechanical bowel preparation alone seems to have no effect on. So okay. if we look at the results, the anastomosis leakage based on its no preparation and mechanical bowel preparation seems to have the same effect. Yeah. Yes, but combining the two together, mechanical bowel preparation reduces the fecal load from the bowel, which we can see during the surgeries that the bowel is emptied. And the oral antibiotic preparation reduces the bacterial load of the abdomen and in the bowels, but after the surgery in the abdomen as well. And combining the two together, I think that oral antibiotic mechanical bowel preparation because it is a laxative, it helps the oral antibiotic to reach the further sections of the bowel in time. So because the bowel load, or the bowel matter needs 2 to 3 days to travel through the digestive system, and with laxatives and oral antibiotics, it can reach the end of the bowel sections or segments in a much quicker way.
Right, thank you so much.